We are into English today, and I'm happy to invite to welcome you all for this meeting, because it is more of a public awareness program. But all clinicians who are also dealing with pregnancy diabetes across, maybe it is obstetrician, maybe it is a physician, maybe it is diabetologist, endocrinologist, across. Even this can be of their help, because we have the esteemed faculty and the guests here are the basically key opinion leader in the field of diabetes and pregnancy. So I welcome you all, and I will speak about pregnancy diabetes at the end, while after the conclusion of the meter, at the time when we give the keynote after the carry-on messages. But before that, this particular session of public awareness program, sir, the last program we had was on Hindi, and before that it was Dogri, that is a Kashmiri language, and we already have completed Malayalam, Tamil, Telugu, Assamese, and Oriya, and Gujarati, and all other languages have already been covered. So today we have the chief guest of this particular program, Professor Dr. A.K. Das, who is the Dean Academics of Balaji Institute of Medical Sciences, JIPMER. He is the past president of Diabetes and Pregnancy Study Group India, past president of API, past president of RSSDI, and he is mentor of all of us, and is a teacher of teachers. He is also the chief advisor and the chair director of Hello Diabetes Academia, which we are doing since last 12 years. So he is a person who has a lot of things to tell us, and he's a person, he talks about the clinical diabetology. That's more important. So every one of us really as a clinician learn from him. Over to you, Dr. A.K. Das, for your chief guest words of wisdom. And then I'll talk about Dr. Usha Sriram. Thank you.
My dear Sunil, and dear Usha, Ajay, and Swati, and all the great people who have joined here. I'll be very brief. I like to mention that the pregnancy diabetes is the most important contemporary challenge for two reasons. Number one, जान से बचे दो जान. ये सुनील का कहना है. Sunil has given this message. He has come in Dainik Jagaran in Hindi in North India. If you test for the GDM, you can save 2 lives. Number one. Number two is the fact that if you want to prevent diabetes in the community, for the primordial prevention, for the ultimate prevention, let us call it for the public language, ultimate prevention, the mother is the key. Is the female gender, as Lisa King tells it, is the key. So this is the session organized, centered around the women diabetes, especially women diabetes, and not women diabetes, about the diabetic pregnancy, and it is followed up with the objective that Sunil has hosted this. It is basically to make the people aware what is pregnancy diabetes, how they can participate, how they can test, how the greatest things are simplest, how they can be a simple test, how it helps. If they do not want to take insulin, we have wonderful drug in the armamentarium, which we're discussing that can be taken, and to remove very myths regarding pregnancy diabetes. Dear friends, Sunil is doing it year after year, the 3rd year, and I have been participated previous years also. And this is a very laudable project. You know, that is the time that is one of his trademark to do this PregaTalks. And I'll be very brief, and in between, whenever necessary, I'll come to give my inputs. But I must tell you that this is a great talk meant for the public. If you know the disease, you have conquered it. So we want to make people know about what is pregnancy diabetes. And that's it. Thank you very much.
Thank you very much, Dr. Ashok Kumar Das, sir. And as he said, that we try to, DIPSI has a motive that we should try to reach to each and every kitchen. If you focus women, I feel we can take care of the health of the whole humanity in future. And that's the main basic purpose of educating or empowering a women across the countries. Maybe it is a metro or urban area or a semi-urban area or a rural area, or even the ultra rural area of the country can get connected through this. And this particular the webinar or this particular recording is going to be there throughout on various platforms. So in future also, if you are if you are not able to attend full meeting right away, you can certainly go through and through the YouTube as well as the podcast and the website, it will be available. Now I invite Dr. Usha Sriram, who's a diabetologist and endocrinologist and Department of Endocrinology at Voluntary Hospital, Mumbai, Chennai.
Chennai.
And she's also Chennai, and she is also the director of and the founder of Divas. Divas is one of the organization which is working for the women health across the country, and she takes the wonderful meeting with international speakers as well as involving most of the KOLs working in the field of women diabetes across the country. And I have personally attended her meeting once or twice and really appreciate her affectionate behavior towards that meeting. She's so much passionate for women and diabetes care that she can fight with people across if someone says something, even small wrong or negative word on this. So that is what is Usha Sriram, and she has a mission, education for people or for women across the country, and that mission is really very much adorable, and which she has. And so with these few words, she is a guest of honor today for our meeting. She's busy and she's presently at Vellore. She has gone to deliver a talk there. Despite her busy schedule, she is available to us. And that is again for the cause of women and diabetes. Over to you, Usha.
Thank you, Sunil, and thank you, Professor Das. Very, very kind words. I'm here for the cause and for you, Sunil. If you call, I will be there. So first, thank you for inviting me today to share this platform in the beginning of the new year. So gestational diabetes is a first reason that I think we all have to take it very, very seriously, is because it's a very big problem. It's not a minor problem. In India, every year, about 2.5 crore babies are born, 25 million babies. That is more than the population of Sri Lanka. Now, out of this 2.5 crore babies, we used to think some 10% of people had gestational diabetes. Gestation means pregnancy and diabetes. So this is a diabetes that shows up during pregnancy. But then I'll tell you why else we should take it very seriously. It's a very big problem. Now we are seeing as much as 15 to 20% of the pregnant women developing diabetes, and in some places even higher. So that means several, lakhs of people who are developing every year this gestational diabetes. The second reason why I worry about it and must take it very seriously, everyone, is because the women who get gestational diabetes are at greater risk for developing diabetes, not in the distant future, within the next 2 to 10 years. So while they're still very young, and if sometimes before they plan their next pregnancy. So it's a very, very important reason to take it seriously. The third reason is the only non-modifiable risk factor is our, family history. Everything else, for example, our weight, we can control it. Other, illnesses and habits that can come from lifestyle, we can control that. And very importantly, age is a risk factor. So women can plan their pregnancies at a reasonably younger age. So we can do many things to, number one, of course, healthy lifestyle and not gaining weight before a woman becomes pregnant. So if all these things are done, the risk for gestational diabetes can be cut down a lot. The third reason why we have to take it very seriously, not only the mother gets diabetes, her baby at a very young age. When I say young, not when the baby is born or as a small child, but as a young person, teenager, maybe 20s, 30s, can develop diabetes, can become overweight, now they're saying the mother and the child can even develop heart problems. So for a lot of reasons, this program is very, very important. And whatever is being said today by the experts, people will have to, take it very seriously. And if they hear things like this is only pregnancy sugar, it will go away as soon as the baby is born, please don't listen to that. Thank you. Sunil will
Thank you
join
very
as
much.
and when.
Yeah. Absolutely. Yeah. Thank you very much, Usha. And we are really proud to have you and Dr. A.K. Das sir as our mentor here. So now we have the panel discussion, which is supposed to be started with the moderator here and Dr. Swati Srivastav. She's a professor and head of department of medicine in Jaipur Medical College, and I feel Savai Ram Man Singh Medical College, if I'm not wrong. And very important that she's very popular lady physician across the country, and to the extent that now she's the governor-elect of ACP India chapter, American College of Physicians India chapter. So we congratulate you, Swati, for your new assignment, and wish you all the best for this. And we know that you have got a lot of interest in women and diabetes, and that's why Dipsy Group has chosen you as one of the moderator here for this PregaTalk in English. So over to you now. You are requested to introduce our panelists as well as conduct the session. And we all three of us are there in the background. Whenever it is required, we will certainly be there to participate. Thank you very much. Over to Dr. Swati Srivastav.
Thank you. Thank you very much, sir, Dr. Sunil Gupta. A very much heartfelt thanks for involving me in this very important Prega Talks as our mentors and experts, Dr. Ashok Kumar Das, sir, and Dr. Usha Sriram were saying. It's a very important issue, diabetes in pregnancy, and discussing some important, simple things which most people should know would be very useful in preventing, bad outcomes and having the best results. So thank you very much for having me here. And we have expert panelists here who will be discussing the important issues. We have with us Dr. Ajay Tiwari. Dr. Ajay Tiwari is a director and consultant diabetologist from Jai Clinic and Diabetes Care Center, Lucknow. He is an eminent diabetologist and has a lot of practice in diabetes and expertise in treating this subject. We also have Dr. Sujata Mishra Das, who had connected, probably got disconnected. She is a director, Postgraduate Institute of Medical Science Research in Bhubaneswar, Odisha. Dr. Lotika Purohit is also there with us. She is Director, Diabetes Care Center, Kolaba, Mumbai. And we have a very important nutritionist, consultant nutritionist and diabetes educator, Mrs. Neeti Desai with us. So I welcome all the panelists on board for this important panel discussion. So as we just heard our experts saying that pregnancy and diabetes, why it does become so important, because in pregnancy, there are a lot of changes which occur in the woman's body. And what is important is the blood glucose tends to rise. And the important thing is that this can have an impact on the outcomes of the mother as well as the fetus. So we are dealing with not one person. We are dealing with the health of two people, the mother and the fetus. And the most important point is most of these things can be prevented very easily if we have knowledge about it. So going for this, Dr. Ajay Tiwari, my first question to you would be, like, with the DIPSI, which is very important, the Diabetes in Pregnancy Study Group in India says that when the pregnant woman first steps into the antenatal clinic, her blood glucose should be tested. So could you just throw some light on this, that every woman to be screened for GDF during a first visit in the antenatal clinic? What do you have to say to that?
Okay. So thank you, Sunil Gupta sir and Swati ma'am, for giving me this opportunity. And we have our respected Ashok Kumar sir with us. So DIPSI guidelines are very centric to India, and we have to understand that we have a higher incidence of gestational diabetes mellitus as compared to the Western population, around 11 times more than that. So that gives us the gravity. And that DIPSI guidelines says that all pregnant women whosoever visit to the antenatal clinic at any time, earliest on, we have to test for gestational diabetes mellitus, and they have given a very simple single step test that is irrespective of whatever is your status, non-fasting state, irrespective of how much before you have taken, you just have to take a 75 gram of glucose in 300 ml of water and test after 2 hours. If it is more than 140, then you have to label it as gestational diabetes mellitus. And it is recommended that we have to go for 2 tests, first at the first antenatal visit and then again at 24 to 28 weeks. So that is the dictum, and as per the DIPSI guidelines and what the government of India, which has adopted the DIPSI guidelines, they say that it is the universal testing is important for all women who are visiting an antenatal visit. And early is important because the studies have shown that around 48% of the women are missed if they are not tested early on in the course of their pregnancy. So that is very important.
So true. Though we know that insulin resistance is an important factor and it tends to come up in the third trimester or the end of the second trimester, but then early detection becomes very important because many a times we have females who have hyperglycemia and are not aware about it, and then we are going to miss the bus if we are not testing them there. So DIPSI, after so many important trials, have shown that the absolutely first time when the pregnant lady comes in interaction with any doctor, the obstetrician, or be it any diabetologist anywhere, she should get her blood glucose tested. I would like Dr. Sunil Gupta to add some points to this importance of universal testing at the first visit.
I appreciate, Ajoy, you're absolutely on very right direction that we have to screen each and every woman coming at the first given opportunity. You should go for their glucose challenge test, where we give 75 gram glucose, irrespective of the time of the meal. If you're coming fasting, good, you can do fasting as well as you can give glucose. Else, even you can give it with the non-fasting and take 2 hour test. Is more than 140 is diagnosed. What is more important, Swati, what Ajoy is actually trying to give importance to is that if you go through the ICMR data, which has just been published last year, you have 10.1 crore as diabetics and 13.6 crores are pre-diabetes. And most of these pre-diabetics are not detected ever in our society. And these women, now the age of onset of diabetes is coming down and the age of marriage is going up. So it's going to mismatch. You are going to have more and more number of these pre-diabetics. And we say, when we try to, in clinical term, we say IGT or pre-diabetes in non-pregnant state is diabetes in pregnancy. GDM is being defined as pre-diabetes in non-pregnant state is diabetes in pregnancy. So that gestational, so we are going to have many cases who are actually pre-diabetes. When they are subjected to pregnancy, they are likely to develop hyperglycemia and gestational diabetes. And that is why this 13.1 crore means every fourth person above 18 years of age. I repeat, 13.1 crore pre-diabetes, 13.6 crore pre-diabetes, 10.1 crore diabetes. So total is going to be around 23.67 crores, which comes to almost 1/4 of the adults population above 18 years of age. 18 years of age population in India now is around 94 crores, 92 crores. So from 90 to 94 crore, 23 crores is almost fourth person. And this fourth could be a woman. Every fourth woman, it applies to both of them, the male as well as the women. So every fourth pregnant woman is likely to have either diabetes or pre-diabetes because she is 18 plus. So even if you consider just pre-diabetes numbers, it is very high prevalence of GDM we are going to face.
I have one comment, Swati. Can I just make it?
Definitely, sir.
Very brief. Number one is the fact that we are having a talk in the Epicon, which is given by Professor Sheshia in person. We have invited him to present there. So his view, you may or may not like, he says, why do you call somebody GDM? Why do you give them the mark or the stamp of diabetes? He says a stigma. We had a meeting about it. He says, call it hyperglycemia in pregnancy. That we'll discuss later. But what is very appealing to me, Sunil, is the fact that in the first 3 months, the organogenesis is over. Am I correct, Sunil? And therefore, testing at 28 weeks, which used to be the earlier recommendation, as Ajay said, early testing is mandatory. Number two, I don't want the media to carry the terminology of whatever you call it, early diabetes and etc. I'm not telling you terminology, but I'm saying to that when the mother, when the married lady misses the first period and is known that she might be pregnant and the test shows positive, that is the time to capture the GDM. That's why early testing till third trimester, there's a window of opportunity. And we also know from the Sesha's paper, missed in first trimester, found in second trimester, missed in second trimester, found in third trimester. Therefore, early testing, and there are few views 8 weeks, 10 weeks, 12 weeks will come to the latter time permitting. But I want this message, as Sunil has given very much importance to this, that we have to get the message that early, when the point of first contact with the obstetrician, because you people see it, we see later. So you have to test for the GDM. Thank you.
Very true, sir. Very true. So the point goes very clear that early testing for blood glucose for looking into whether there is any hyperglycemia in pregnancy is very important. So the first time a pregnant lady comes in contact with any, she realizes that she's pregnant, she should get her blood glucose tested, and then it look accordingly. She has to be seen for the rest of the gestational period. That will as to one-step diagnosis, a single-step diagnosis, which is very much helpful, especially in our setup, because in Indian setup, our females may be coming from far and wide. They may not be having the possibility of being fasting, because if they're coming, suppose from a village, then they cannot fast for such a long time. Then they cannot wait for a very long time also. They have to go back also. So the single step diagnosis is quite useful. So can you throw some more light on this as to how they should be tested?
Yes, thank you. First, I would like to thank Dr. Sunil Gupta for initiating this, and also Dr. Usha Sriram, Dr. Ashok Kumar Das. 1 minute, I would like to add just to what Dr. A.K. Das said. Actually, we think that, probably the time of the first time when when the woman is pregnant is when the sugar should be tested. I think maybe we should also think that of premarital testing before they get married, instead of spending so much money on the weddings and things like that. A simple blood sugar at that point of time also would make some difference to see whether these are diabetic. Maybe an HbA1c or something can be done pre-maritally also, though nobody plans a pregnancy most of the time, so it's very difficult to probably practically put it in place. Another thing is, like, yes, now the single step testing is something which is very important. It should be done because unfortunately in our healthcare system, we see a patient today, we don't know when we will see the patient again. So it is better that whatever time we are able to connect with the patient, we should ensure that we are able to do the testing to see that if they are a potential to get diabetes during the course of their pregnancy, and if they are able to get, if they are going to be a potential diabetic or a potential gestational diabetic, then diet, exercise, and whatever else medication required can be started at an earlier stage, rather than waiting for some problem to happen and thereafter dealing with the consequences.
Very true. Dr. Ajay Tiwari would like to say something about the single step diagnosis that has been recommended. You would like to add something?
So actually, this is what the single step given by the DIPSI has been accepted by the WHO also. And this is as a wide acceptance all across the world, except for the AICOG, which is still halves on the 2 or 3 step diagnosis. So basically, this is easy to do, and it is very pertinent to our settings because the patients are not coming in the fasting state, and we do not know if the patient will come for follow-up or not. So irrespective of the fasting state, whatever she comes, we just give her a challenge of 75 grams of glucose, and you check after 2 hours if it is more than what. So that eases up very importantly. And if you see for a doctor who's sitting in a periphery and the patient, usually the village ladies, they are not amenable to coming fasting. They are not even aware about these things. So if you give just a challenge, a 75-gram glucose and test after 2 hours, I think it is worthwhile. And this has been validated all across. And the biggest thing is that the World Health Organization has accepted it as a standard of diagnosis of gestational diabetes mellitus.
And Swati, most important issue is the fact, if you do not do in the first stage, single stage, there is 50% no-show. 50% don't come back. That has been the statistics in our country, Swati. So if you do not do in the single stage, they will losing 50%. They don't come back.
That is so true. That is so true. And they have their own limitations. They may not be able to come back because of so many limitations. So when she is there with us, it's better to do it and to diagnose and then prevent further complications. That is very true. So after we have seen that we have diagnosed, we have selected the woman where we've seen whom to test, and then we have diagnosed the patient to be having hyperglycemia, then diet plays a very important role. So we have a nutritionist expert with us, Mrs. Niti Desai. I would like to ask you that what diet patterns would be useful in all the 3 trimesters as well as in lactation for patients with diabetes, because this is one place. Diet is one issue when people have a lot of myths and they have a lot of wrong beliefs. This should be given, this should not be given, this because a lady is pregnant and as compared to the non-pregnant state. So could you please enumerate some detail about it regarding the diet, which is should be given in the 3 trimesters as well as lactation?
Yes, thank you. On the outset, I would like to thank Dr. Sunil Gupta and Dipsy for having me on this session, which is a wonderful initiative. So the nutrition, when a woman says or announces that she's pregnant, there are suggestions coming from all members of the family. It starts with eating for 2. You need to eat for 2 now, and that's where the myths start. So one, women are not supposed to eat for 2. Secondly, if we talk about first trimester, we are not looking at any increased caloric intake. In fact, if the lady is overweight or obese, we take that opportunity in the first trimester if she could even lose a couple of kilos. Often because of the morning sickness, women are not able to eat, then also they lose some weight. So first trimester, there is no calorie increased. Second trimester, we are looking at a caloric intake of increase of 340 calories. Again, this is if we are talking about women with normal weight. But if a woman is overweight or obese, the overall weight gain that we are looking at during pregnancy is also different. It is titrated. So for a overweight lady, we are looking at a weight gain of 7 to 11.5 kilograms during the entire pregnancy. And for the obese lady, it's just 5 to 9 kilos. I think this is where the education starts, when we tell them that you only have to gain 5 to 9 kilos and not 12 to 18 kilos, 15 to 18 kilos, what they've seen or they've heard. That's where the whole battle starts. So the caloric intake will have to be individualized depending on where the lady begins her pregnancy. Second and third trimester, the caloric intake may have to be increased or maintained depending on the weight gain. I think more important is where the calories are coming from when we are looking at this population group. And the challenge with our Indian diet is that it's extremely carb heavy. We love our carbs, so we are a carb loving nation. So the important thing is to tweak the diet, reduce the carbohydrate intake to around, say, as suggested, to around 45 to maximum 50% of the total caloric intake, which comes to around still 160 to 175 grams of carbohydrates. And more importantly, increase the protein intake. So which in food terms means that we need to completely avoid, of course, the sugar and the sugary foods. But besides that, all the refined products like maida-based items, which starts from khari to butter to white bread to the regular noodles, pizza, pasta, all this needs to be cut down, and they need to be replaced with healthier options or just increase the protein intake. And these are some simple tweaks depending on the region that we are talking about. So if it's aloo paratha, we just need to make it into a gobi paratha or a mooli paratha and a katori of dahi, and it becomes a healthier snack. It doesn't have to be completely different. So all in all, reduce the carbohydrate intake, up the protein intake. The fat intake is to be moderated at 25 to 35%, which is not a big challenge. The biggest challenge is cutting down the carbs, replacing it with some protein. Lactation is the time when the caloric intake, in fact, is the highest, even compared to the 3 trimesters. That we are looking at almost 450 to 500 calorie increase. But again, in practice, we have seen that a lot of women, in fact, gain a lot of weight on the first 40 days when they are being fed a lot of shiras and laddus and whatnot. So again, there also we need to take care of the caloric intake, because if you gain sufficient weight, then we don't need to gain some more weight post-pregnancy.
Very true. So that becomes very important, because medical nutritional therapy is the very important backbone of management of hyperglycemia in pregnancy, as we all know. And diet is very important, and very rightly pointed out by Mrs. Nitish Desai, that in our Indian ethnic setup, basically having a high carb diet and having a lot of list of do's and don'ts. You eat this in pregnancy, you eat this in lactation, you don't eat this in pregnancy, you don't eat this in lactation. The patients may tend to be doing a lot of mistakes, and they need to know about all these things, that changing not the quantity but the quality of diet, making it more, bigger cereals and not refined products, and more of fiber contents and more of protein would be useful. Yeah.
Swati, can I add something?
Hello. Yeah, am I audible?
Yeah.
Yes, I was going to ask you also, Dr. Usha Sriram, ma'am, definitely you would be guiding us, definitely. Ma'am, you please tell us something more on this.
I just wanted to say that excellent points made by Niti. A couple of things is that usually women have lower tolerance to carbohydrate in the morning, and it kind of improves during the day. So we prefer to recommend less calorie distribution, I'm saying, less in the morning. And usually we say, right, eat bigger breakfast and eat less at dinner. Here it is a little bit reversed, because also throughout the night, the baby gets all the food from the mom, and there is a greater tendency for the mother to actually get, her sugars to dip down in the morning. So better to eat a little less in the morning and a normal amount at dinner time, so that it sustains her through the night. And it has to be a very culturally appropriate meal. So usually what I do is I culturally appropriate and appropriate for them, their life, their purse strings, their, everything is suited to them, right? We can't give one pre-printed sheet, and that's not the diet. So take a history of what is your typical day like, what is the nature of their work, and then tailor a diet for them, including normal, the traditional foods that they are used to eating, and not something, nobody needs to eat anything different except 2 glasses of milk. So I usually tell women, don't eat for 2, eat for 1.2. And the 0.2 is 2 cups of milk.
So that is very true. That's a very important point, Madam has made, that it has to culturally suit them and make it comfortable for them. Otherwise, they will not be compliant with it, with whatever advice we are giving. Moving ahead with this, in addition to medical nutrition therapy, which is the backbone, another very important aspect is exercise. Now, again, there are a lot of queries about exercise, whether a pregnant woman should exercise, how much she should exercise, though we know that exercise is a very important aspect whenever we talk about controlling hyperglycemia. So I request Dr. Lotika Purohit to just throw some light on the importance of exercise and what can be done by these pregnant ladies to prevent hyperglycemia and control it.
Exercise is very important during pregnancy. Of course, the amount of physical activity would depend on the clearance that the gynecologist also gives. I mean, if there's a high risk pregnancy or some problem, or there's any other contraindication for exercise. Otherwise, I think most women should be told to walk at least 20 to 30 minutes every day during all 3 trimesters. A little light yoga also is something which will help. It kind of relaxes the mind. They get better sleep. There is better flexibility of the muscles and the bones. And this facilitates or maybe supports them to have a higher chances of having a normal delivery. Besides that, it also reduces the complications of the cardiovascular complications, as well as the diabetes related complication incidences are much lesser if they are exercising regularly. Of course, like I said, if the gynecologist has said there is a contraindication, then exercise should be advised, should be probably tailor-made as per the amount that they are allowed to do. But most of the time, walking and yoga should be supportive.
Latika, even
yes.
upper body exercise, Latika?
Upper body exercises, yes. That is also there. Even if they are supposed to have bed rest, they can still do upper body exercises.
True, very true. So upper body exercises in conditions where they cannot do the entire schedule if there is some contraindication from the obstetrics point of view, or from even the medicine or the cardiovascular point of view. And in patients who do not have any contraindications, exercises definitely have a very important role, because as we say, that there are 4 main aspects of management of diabetes, one being the medical nutritional therapy, one being exercise, third being the monitoring, self-monitoring, and fourth being the treatment with insulin. So now moving ahead to treatment part. Now, once a lady has gone on medical nutritional therapy, she is doing exercise, she is complying with the lifestyle modifications. And in spite of that, she is not, her blood glucose are not coming under control. Or, for example, her blood glucose are quite high, which require immediate treatment. So in these cases, we need to institute some form of treatment. And we all know that in gestational diabetes, we are worried of whatever drug we give should not be affecting the fetus and should not be being transferred to the fetus. And for that, insulin is usually the drug of choice. So what do you think, Dr. Ajay Tiwari? Could you just give some aspects about how we can manage these patients with treatment, and how insulin or for that matter, any other medication would be useful in these cases?
Okay. So the standard guidelines are that we have to go for a lifestyle management for 2 weeks. And if it fails, then we have to think about the the management about these things. So as you have already said, that the insulin is the drug of choice. And as regards to the oral hypoglycemic agents, so as regards to metformin, we have got a lot of studies which have shown that it is not teratogenic for sure. But most of the recommendations and our own DIPSI recommendations says that you should not use it before 20 weeks of gestation. So that is what we have to understand. We have to focus on insulin, and that insulin has to be tailor-made, as the dosing of the insulin is to be tailor-made as per the self-monitoring of blood glucose values that the patient is carrying, because that is a gold standard during the during hyperglycemia of pregnancy. So you have to tailor-made the insulin requirements as per that. And If the patient is not amenable, then you can consider glyburide or metformin, what the ADA says and what all of the recommendations that we follow says. But our DIPSI says that metformin use should not be done before 20 weeks of pregnancy. And I think that is very justified, because basically this entire concept of insulin resistance is to facilitate the fetal nutrition. So that is something which is to be understood, that is something which is important for giving optimum nutrition to the fetus. So we do not need to compromise this, because same thing happened in some trials also, that we had small for gestational age children who were on metformin. So that is to be understood. And so this is what I say. And the insulin that we have to give, that is to be tailor-made as per the patient's requirements.
So
Depending.
true, very true. Dr. Lotika, you want to say something?
No, I think I agree with Dr. Tiwari. I think we should ideally prefer insulin. Of course, metformin is something that we do use. A lot of people do use glibenclamide, but I don't think the studies, and it's just usually for a very short period of time. So if we explain to the mother that, for a few weeks, it's better to take insulin so that there is a better chances of your child being normal, having, all other parameters within normal limits, I think they usually agree. So it's
Absolutely.
something that. Usha madam, what do you say?
Yeah,
So
Dr. Usha.
I don't think we should use glibenclamide, and
Yeah.
anyone who's using should stop using it, because there is increased risk of babies getting admitted to NICU, and also low sugar, and also baby weight can also go up. Now, as far as metformin and insulin, as everybody agrees, insulin is like the gold standard and drug of choice. So either we can have the principle that if somebody cannot or will not take insulin, they can use metformin, is one option. Another one is if the mother is overweight. They've shown that she doesn't gain much weight with insulin, and that's one good thing. But if the mother is already underweight, or if the baby is not growing, then we should not use metformin, because one side effect of that is the baby can be low birth weight. So if the baby is already not growing well, or if the mother is underweight, we should be careful. Otherwise, I think the safety of metformin in pregnancy is, most people feel comfortable, using it, and it has a place in the management.
There are some absolute indication and contraindication for metformin. What Dr. Usha Sriram has said, that if someone has a placental insufficiency, preeclampsia, means blood pressure in the pregnancy, IUGR, if there is a IUGR, oligohydramnias, polyhydramnias, any complication, vasculopathy, in such situation, or multiple bed obstetric histories, in such situation, we should avoid, and insulin remains the drug of choice. So that's the gold standard.
Absolutely true. So these are the specific contraindications where we should absolutely
Glibenclamide
not use.
Glibenclamide has not been used in our population. So better we don't talk on this. I absolutely agree with Usha here.
Yes.
So true. So gold standard is insulin, and metformin only if the patient will absolutely not use or cannot use, because the risk of not controlling the hyperglycemia is even more. So only in that circumstance. Otherwise, the gold standard is insulin, and we have to keep that the contraindications of metformin, that IUGR, chronic hypertension, and the ones Dr. Sunil had mentioned, are very important to be kept in mind. Yes, Dr. Das.
Equally true, Swati. One thing is also equally true, that 70% of your obese women or GDM women will do well on diet therapy alone. And remaining 30%, few of them will really do well with only metformin. And many obstetricians, they love metformin.
Yes.
So even we as a diabetic and all, go on proposing, we know that insulin is the best, because insulin doesn't cross the placenta. See, insulin doesn't cross the placenta. All oral drugs, they cross the placenta and enter into the fetal circulation. So for laymen who are listening to it, for them, that insulin doesn't cross the placenta, that is why it is the best. and all drugs can cause placenta. But metformin is otherwise a safe drug. Now, even European organization has now said that it can be used from preconception till delivery. Nice guidelines. So that way, unless and until it is contraindicated. So of course, the obese woman requiring very high dose of insulin, even you can just add metformin and your blood sugar gets well controlled. So there will be some exceptions. But Swati, I agree on your point, and we can certainly have this consensus of having metformin when it is required. When it is not required, should absolutely not be used, and other oral drugs we should avoid it. And insulin remains the drug of choice.
I think the point I wanted to highlight, that Government of India guideline, which is the yellow book, Sunil and Swati, which has been published twice. In the second edition, we send insulin and metformin can be used, but the caveats of insulin of metformin, which you highlighted, are also in the book, in the box. Now, the benefits of metformin beyond what you have said is also in relation to maternal and neonatal outcome of having low hypoglycemia, lower maternal weight gain, and also lower macrosomia. So that's why it is probably a drug which will be given. Now, I would like to know what dose that you recommend, Sunil. How much dose you recommend, or depending on blood glucose? You recommend 250 BD, 500 BD. What's your recommendation, Sunil? Metformin. Or for that matter, if Usha is here, or Swati, can you just mention what is your recommendation?
I'm here, sir. No,
yes.
I would start with 500 once a day. And then you can, it's only because, see, the other thing is metformin can sometimes cause like a gassy feeling or vague abdominal pain. And in a pregnant person, anytime they have abdominal pain, they start thinking it is some labor pain and all that. So start with 500 once a day, and then we can, gradually build it up. It's approved for even up to 2 grams, but most people need only about 1 gram a day.
Yeah, correct. 500 BD. Now, Usha, in the booklet also, I think you must be the author there. We have also given a box where we have said where metformin may fail, in addition to what Sunil beautifully said. And we have said in the book, metformin may have a higher rate of failure where there is earlier diagnosed GDM. If there's an early GDM, the second time patient getting into GDM. Number 2, if there's a very high blood glucose level, higher BMI, and previous history of GDM, I already spoken about it, and if there is a insulin, that these are the things where the metformin may fail. I would like to know the opinion of the House regarding the metformin giving sustenance of the, it stays in the implantation and also the safety to the product of conception. Usha, do you believe in that? That metformin gives some benefit to the product of conception?
No, sir. So in all studies, with most of them agreeing that it is as effective as insulin. Okay. Yes. And of course, there's contraindications. It causes less weight gain for the mother. Yes. And in fact, mothers prefer it naturally over an injection. Yeah. But the only question that still remains after all the studies is still if there is any cardiometabolic programming of the baby that is, could be negative in the long run. So that is the only question still unanswered, which is why I think we are still saying, let's use it, when needed, and use it not in big doses, in a doses needed only. And also people who have all those contraindications, we don't use it.
Exactly. So, I think that we have to highlight. I think the public education about this, insulin is number 1, number 2, number 3. If there is a contraindication, person not going to take, metformin can be used safely, bearing this contraindication discussed. I think that should be conveyed very simply. Yes. We'll not go to the MIG data and all for the purpose of this meeting. But what is the latest MIG data on the cardiometabolic profile? I thought it has been so far so good. Usha?
So, what all the different data, whether it is MIG or from the HAPO or from, the Adelaide, Auckland data, all of them. So they, basically that the cardiometabolic thing is the only one that is still at 9 years also. They're finding some of the changes, that the weight of the baby and the subcutaneous fat and all that is high.
Yeah. Thank you. I think we have enough discussed, Swati. And so you summarize to the audience, very important aspect, that insulin is number 1, number 2, number 3. As you rightly said, drug of choice, but metformin can be used. In fact, I'm very happy that, Usha, that our obstetricians are using metformin if the person not willing to take insulin. That has given a lot of good control. That must be emphasized, that metformin can be used with confidence if you take out the other contraindications. Thank you.
Thank you very much, sir, for that very important discussion on insulin and management and metformin, if at all, in GDM. Moving further, yes.
We must also tell to the public that if the insulin requirement is very high and obesity is too much, then we can combine.
Yes, because their insulin resistance is an important factor, and metformin definitely helps in that. Self-monitoring of blood glucose is the next point which I would like to highlight on, because that is a very important aspect of control and managing the hyperglycemia in pregnancy. Mrs. Neeti Desai, please tell us something about how one can and how frequently one should monitor daily, and the importance of self-monitoring of blood glucose. And plus, many patients have a lot of myths about using a glucometer, which is the most important thing. Otherwise, it cannot be done. So, what is the importance, how it should be done, and how frequently one should monitor and control it?
Yes, as we know that blood sugar control, blood glucose control throughout the day is important. It's not only about the fasting level, which a lot of people only do the fasting and they think that is fine, so we are okay. You're in GDM, in this phase, we expect and we would like that patients, the ladies have almost a 7-point reading where we do fasting, we do 3 pre-meals, 3 post-meals, and then a bedtime. But when that is not possible, then we definitely want 4 readings where we do a fasting and 3 post meals, after breakfast, after lunch, and after dinner. Because in GDM, generally what we see is that there is a post meal hyperglycemia, the blood sugar spike after the meals. So what again we've seen in practice, that in fact, I love to work with this population because they are very compliant. Most of them at this stage in life, they are ready to do anything for the baby. So they are happy to prick themselves, happy to check their sugars a lot more often than they would have done otherwise. So that is not a challenge, but when there are challenge of resources, other constraints, then definitely till the sugars are not well controlled, we would want post-meal sugars and fasting. Once the sugars are well controlled, and if they are not on insulin, they are just being managed with medical nutrition therapy and the OHA, metformin, then it does not need to be that frequent. We could even have a couple of readings through the week once it is controlled. But somebody who's on insulin and the sugars are not controlled, we need very regular SMBG, serial monitoring of blood glucose. And as I said, luckily, most of the patients, they comply.
Yeah, Dr. Sunil Gupta,
I feel very straightforward message for everyone. Once you are diagnosed to have GDM, you should be monitoring it very, very regularly. But rightly said that if she is just on diet therapy without any pharmacotherapy, you can monitor maybe twice a week. But you have to monitor fasting, post breakfast, post lunch, as well as post dinner, because GDM is a state of postprandial hyperglycemia. So post meal goes up. So sometimes you miss out those post dinner reading, which is going 140 and 150, and breakfast is 120, less than 120. So one should not miss out that. So that is one thing. But if you are on insulin therapy, you are supposed to monitor at least 3 to 4 readings per day. Ideally, 6 to 8 readings per day. Those are type 1 diabetes on basal bolus therapy. So always more you monitor, better is going to be the neonatal outcome as per the evidences we have. So monitoring is at most important.
That's very important, and a clear message to the patients that the monitoring is going to really help the outcome of their baby, and not only immediately, but it's going to affect the baby later on also, which we'll be discussing in the coming some minutes. So it is important to monitor, and this goes a long way to help. Nidhi,
As the pregnancy goes up, your blood sugar shoots up.
goes up.
So, yeah, so you have to be for first trimester, second trimester, then third trimester. Every week it's going to increase, and that's why you are supposed to monitor it very closely.
Yes,
Ajay.
Dr. Ajay.
So actually, I want to say that no laxity should be given as regards to blood sugar testing. As Sunil Gupta sir has already said, that this insulin resistance will keep on increasing progressively till 34 week. So we have to be very particular about this thing, and we have to ensure, and we have to keep on intensifying our insulin regimen as per the increasing insulin resistance. So testing, at least 4-point testing, I think is very, very important. If you do like that, so at times we do, once the patient is having a stable blood sugars, we are going for 2 days, we're doing the first two, then second two, like that. But I think that is very important, that the testing is the most important part, because that will define what we are going to get out of this.
Absolutely true.
At one point, Sunil, you must mention that nowadays that this CGM is increasingly used, especially in pregnancy. What are the targets as compared to normal non-pregnant state, and how much is allowed, that you must mention.
CGM CGM is being used in patients, especially those are type 1 diabetes or type 2 on multiple doses of insulin therapy. So CGM is a continuous glucose monitoring system, which is usually put on your left arm or sometimes in the abdomen, the newer ones, which monitor blood glucose regularly for every 15 minutes, but they monitor every 5 minutes and being stored as every 15 minutes, and they can be seen even now you're on your mobile. So according to the blood glucose, according to the interstitial glucose which is being monitored by CGM, they can adjust the doses, but it actually monitors a trend. Now it gives you two important things. One is TIR, time in range. So if it is a gestational diabetes, we expect the time in range is between 63 to 140.
63 to 180. Yeah.
So your 24 hours, your 90% of your reading should be between 63 to 140. When it is type 1 diabetes, it can be 70% and not 90%. So this is very, very important for the doctors especially. And if some patient is being advised CGM, you should certainly listen to a doctor and should use it, because a doctor will then interpret whether you are managing your blood glucose well. And those who have less amount of glycemic variability and wonderful control throughout 24 hours have a better baby. So you don't have to have only baby, you also have to have a healthy baby. So for a healthy baby, you have to have good monitoring and good glucose control throughout the pregnancy.
And also highlight, Sunil, that the monitoring criteria is same as the diagnostic criteria. We want to maintain the same diagnostic criteria blood glucose while monitoring, and same criteria for the postprandial.
So postprandial we have target of 120.
We can
2 hours, yes.
90,
2 hours is 1 hour is 140.
1 hour is 140 and 2 hours is 120.
120 and fasting is 90 or 95.
Yes, 90. Yes, yes. Thank you.
So a good strict control is very important for good outcome, for which a good monitoring is, and a self-monitoring, which the lady has to do herself, is very important. That has to be understood and communicated and done by the patient. So moving ahead, regarding the ultrasound studies which are done frequently by the obstetrician, Dr. Ajay Tiwari, do we have any significance with related to this topic that we're talking about, gestational diabetes, in brief?
Okay, so basically watching for the fetal well-being and the proper growth, IUGR, I think serial ultrasound monitoring is very important, but it is the purview of the obstetrician who is seeing the patient. So we definitely would recommend that we have to see, and we have to see that what type of glycemic control we are providing to the patient, and if the patient and the fetal is growing in the right way or not. So serial ultrasonography is very, very important and pertinent. That is very important. important. You have to look for polyhydramnios and all those things. But I think that is more to be at the discretion of the obstetrician who is treating the patient. She defines the frequency and the timings of the ultrasonography.
So true. So then moving on further, just a small comment, Dr. Lotika, whether it's a myth. It's usually people feel that it's a macrosomia, a large baby. So cesarean section is important. Just in very brief, in one line, could you just tell us that whether LSCS is needed is compulsory for GDM or it is not?
It is not compulsory. But it depends on several factors. It depends on the blood sugar control. It depends on the size of the fetus. It depends on the other complications which are there and if there's any fetal distress. Of course, the gynecologist is the one who takes the call. But usually if the patients have monitored their blood sugar well, they are maintaining good glycemic control, the size of the baby is good. Not in macrosomia or something, most of the times we are able to deliver normally.
So then moving on to the further complications which we expect, especially in the newborns. Dr. Ajay Tiwari, what are the various complications? Because in hyperglycemia in pregnancy, we know that there is of changes which are there. Some complications we look up to and we are careful. We examine for these complications when a newborn is born. So could you just throw some light on to what are the various complications we can think of and accordingly managed?
So once we are talking about hyperglycemia pregnancy, so first part, say first 8 weeks or 10 weeks are basically we are interested in looking into the congenital anomalies. But if you are looking per se for gestational diabetes mellitus, we are more interested in seeing macrosomia, hypoglycemia in the child born, or IUGR. So all these things are the things that we have to look in the children once they are born, and we have to understand. And then there is also a chance of that IUGR is very important, and small for gestational age child could be there, or a large for gestational that could cause complications for the mother. So for GDM part, we are more interested to see we are more concerned about the mother, because the child, the growth of the fetus could be large. There could be a different difficult delivery. So those things are important. The second part of the pregnancy is more about the mother, the complications to the mother, and the first part is about the child.
So if we can say like that, if I can summarize, then the postnatal complications, if we say for the fetus, like if we say usually large for gestational age and macrosomia, so relatively large baby is what we can expect. Respiratory distress syndrome can occur. And there can be neonatal jaundice also, neonatal hypoglycemia, because the patient, the lady is taking a lot of drugs for, if she is on drugs, then we can expect, if she's on something like medications, then we can expect neonatal hypoglycemia to occur, polycythemia, low calcium, low magnesium, shoulder dystocias, these all can occur. And with regard to mother, if we say then what effects we can expect because of this high blood glucose, then there are higher chances of preeclampsia, high blood pressure, birth trauma, and increased risk of developing diabetes later on. So moving further with that, Dr. Lotika, what would you like to say on the drugs for lactating mothers? Because once the mother is lactating, then what do we do for her management? Because the list of drugs that we have, many of them, they are seen in they do pass on to the breast milk, some do not. So Dr. Lotika, what would you say about that?
I think she has left.
I think she got disconnected. So Usha ma'am, you could just give throw some light on drugs for the lactating mother. As we know, insulin does not go into the breast milk, so that is a very safe option. Medications, most of them do pass into the breast milk, so probably we have to be careful with whatever medications or oral agents that we are giving after delivery also, because many times it's a feeling that now she has delivered, now you can give her anything, but we have to be careful that she's lactating.
Yeah.
So
So the good news is most moms, as soon as the baby is born and the placenta is delivered, their sugars normalize. And by the time they go home a day or two later, the sugars are normal. So they need to be continue to be on a proper diet, especially because we know that she's at greater risk for developing some, diabetes, possibly in the near future. So always good idea to eat healthy, be on a diet, bring the gestational weight gain down, be active, and get back to the pre-pregnancy weight as quickly as possible. And breastfeeding is definitely going to help a lot in that. It's good for the baby, good for the mother, and most importantly, very high chance of preventing future type 2 diabetes by breastfeeding. So every mother who has had GDM must exclusively breastfeed for 6 months and complementary for another year or year and a half, as much as she can. So what about the medicine? So since most don't need anything, the ones who need, if the blood sugars are very high, or if they have pre-gestational diabetes, meaning they had diabetes before they got pregnant and they were on insulin, they need to go back on that. So that's fine. But the others, metformin is fine. It does go into the milk. Even sulfonylureas, a little bit goes into the milk. So we still use them. But what we have to do is use the lowest minimum dose, tell the mother to first feed the baby, then take the tablet, so that by the time they feed again, 2-3 hours later, the levels have come down. So after 6 months of exclusive feeding, they can always give the complementary milk formula feeds during the next feed, so they can adjust like that. But we just have to keep remembering that the lowest minimum dose, and to try to give it after she has breastfed the baby. And short-acting tablets, not something that works definitely not medicines like glimepiride or glibenclamide and all that, and not things like DPP-4 or so though there are studies going on, DPP-4, SGLT2, all that we don't use now, only metformin and short-acting SU, like maybe glipizide.
very true. Very important points or rather pearls, I would say, of management. Dr. Usha Madam has mentioned that lactation, breastfeeding is a very important part, which has to be, the woman would benefit with it. And we have to be careful about using the smallest possible dose and post feeds, so that the woman is also managed by it and it doesn't cause any hypoglycemia in the child. So moving further, just a few important points. A very important point, I would say, is regarding the offspring of the diabetic mother. Dr. Ajay Tiwari, what would you like to say that what are the long-term complications that offspring may have because he was born to a lady having hyperglycemia during pregnancy? As we know, it has long-lasting effects. Please detail somewhat regarding that.
Okay, so there is a very interesting concept, that is FOAD. That is a fetal origin of adult disease. So we have heard a lot about these things, and this was the cover feature of Time magazine around 10 or 15 years back. They said that everything that you get in future, that is defined what you are during the pregnancy. So that is very important. If the patient is, the child is, the pancreas, the child is exposed to higher levels of insulin, or he is exposed to these drugs. Like a lot of talk was happening about metformin also. So whatever is happening to the mother, whatever she is taking, whatever is her nutritional status, that has a bearing on the child. And these childs are predisposed to obesity or future diabetes, what we call as a transgenerational uh, uh, transitional transfer of these diseases. So that is very important, and that is why we need to understand, and we need to control and give an optimum control to the mother. And these children are, because what was being told about the MITI trial, also MITI tofu trial, which is sorry, MIC tofu trial, which was they found that these children at 9 years were having more of waist circumference or increased skin folds. So definitely we have to watch these children, and these children do have a propensity to have future diabetes or cardiovascular complications. Still, this is a very gray area and needs to be further elucidated by the
Very
trials.
true. And that is why it becomes very important to take so many precautions and do everything as advised by the doctor. And as we have been discussing in the past hour, it becomes very much important to control hyperglycemia as much as we can. So I think with that, we have covered most of the aspects with very much good intercepts with Dr. Usha Sriram ma'am, Dr. Ashok Kumar Das, Dr. Sunil Gupta, and our panelists, Dr. Ajay Tiwari, Dr. Lotika, and Mrs. Neeti Desai. I would request Usha ma'am to just give a message to our the people who are listening to us.
So I want to echo again what Lotika said, that it is best to get healthy before you become pregnant. You can prevent a lot of these complications. So have to get pre-conception care, get healthy before getting pregnant. That's very important. And then, of course, as soon as you find out you're pregnant, get your sugar checked. And even for any reason, if it is not ordered, you can remind your doctor to order it, and that has to be tested. And depending on what has been diagnosed, follow the instructions very closely, because by following it, you can have a pregnancy and a baby like any woman who does not have diabetes. That has been established. So that's very, very important to keep in mind. And after the baby, now it is time to take care of your health, must return to pre-pregnancy weight and plan the next pregnancy, and breastfeeding should be done.
Thank you very much. That is very important. Dr. Sunil Gupta, some important pearls from your side, messages to the audience.
Let Dr. A.K. Das sir first speak, and then I'll just conclude it.
I'll be very
Could not
brief.
see Dr. Das. Yes, sir. Yes, sir. Dr. Ashok Kumar Das, sir, some important points. You have thrown a lot of important light on so many aspects. What would be the message you would like our viewers to take from this?
I should say that for the future generations and the future of the nation, you need not alone focus on the fetus for the future, also focus on the mother with diabetes for protecting the future. Because we have a usual term, focus on the fetus for the future. You have to also focus on the mother for the future. Because diabetes, when it occurs in women, Usha has described it, it is difficult, it is different, it is distressful, and often dismissed. Thank you. So these 4 Ds.
Very true, sir. Very right.
It is when it occurs to women again, it is different, it is difficult, it's distressful, and women like me and Sunil or many times dismiss it. Thank you.
Yeah.
Thank you, sir. Yeah, very, very well said.
Well said, yeah.
Dr. Gupta, you would like to?
Swati, I'll just say that I'll just summarize everything once everyone is done, and then maybe Neeti, you can speak for a few seconds.
Yes.
And Ajoy, and then Swati, and then I'll just give a summary of everything, and then we'll conclude.
Yeah.
Yes, I would just say that GDM is in fact a window of opportunity to move towards a healthier lifestyle. It's not a restricted diet or a restrictive lifestyle. It's not a burden. In fact, this is a great opportunity to start eating healthy and continue this for the entire life cycle for you and the baby. Thank you.
Dr. Ajoy, sir.
So my intent is that the postpartum period is usually overlooked. So that is actually the 4th trimester. So that should not be missed. And the patient at the time of after discharge from the hospital and 6 to 12 weeks thereafter should be tested for OGTT. That is very, very important because that will define the future course of the disease. So look postpartum period as the 4th trimester. Yeah.
So Swati, you want to give some message?
Yeah, just one point that as we know that pre-warned is pre-armed. So, being aware of one's glycemic status is very important. That helps you a lot. I would just say to the viewers, if one is diagnosed as having hyperglycemia in pregnancy, not to get disappointed too much, because we have so much to do, which she can do, which we all can do together. So we can prevent any worse outcomes. We can have the best outcomes and we can manage it best. Back to you, sir.
From my side, Swati, thank you very much, all the panelists. Thank you, Swati, for wonderfully moderating the session. And before I conclude, just summarizing everything. And thank you, Ajoy. Thank you, Niti. Thank you, Usha. Thank you, Ashok, sir. Thank you, Lotika. And of course, Sujata madam has joined for some time, could not make it because of some technical issues. Now, important message in 30 seconds. One is every woman in the country at the time of pregnancy should be screened for gestational diabetes. Irrespective of the first given opportunity, you should do that. GCT, glucose challenge test of 75 gram glucose, take 2-hour test, more than 140, diagnose. First step, diet therapy, exercise, try to achieve 90 fasting, less than 120 post meal, monitor fasting, post breakfast, post lunch, post dinner regularly. Try to achieve these targets with medical nutrition therapy, exercise. Within 2 weeks, if it doesn't do well, meet your doctor. Start some pharmacotherapy. If metformin is not contraindicated, people will put you on metformin. If it is contraindicated, not controlling a blood glucose, then of course insulin remains the drug of choice. Insulin is the drug of choice. As the pregnancy progresses, advances, your pharmacotherapy, maybe it is insulin or sometimes metformin will go up. But as Usha said, metformin sometimes causes GI upset. So dose should be little moderate, lesser dose. That's what we recommend. So maybe up to 1 gram, sometimes up to 2 gram, though it is recommended. People may not tolerate it. So insulin remains the drug of choice. At the time of delivery, one should know that the Caesar is not compulsory unless and until there is obstetric indication for cesarean section. It's not necessary. Last but not the least is at the time of delivery, keep the blood glucose at the time of delivery, whether it's Caesar, whether it's normal labor. You should try to keep the blood glucose between 90 and 120. If it is more, then the neonatal hypoglycemia risk is higher in the baby. So keep blood glucose normal even at the time of delivery, because sometimes you put dextrose drip and all, and that might increase the blood sugar in the maternal circulation, which might precipitate hypoglycemia in the baby. And last is the postpartum follow-up of the mother, as well as the breastfeeding. These are important things. More you breastfeed, you protect the baby as well as the mother herself. Minimum 6 months, even up to 1 year, if someone can manage it, will be really protecting the babies. And of course, insulin again remains a drug of choice in lactation. But but few of the oral drugs like metformin or glipizide can be given in rare situation. Insulin is the drug of choice. And last but not the least, everyone has emphasized on preconception as well as the fourth trimester. What Ajay has a newer terminology he has just quoted here. Fourth trimester, that is postpartum follow-up of these women. These women are likely to become diabetes in next 5 to 10 years. Almost 50% of them will become diabetes. Our own data from Central India says that almost 50% become diabetes within 1 year after delivery. And that is why we should be aggressive in monitoring them before they become they develop second pregnancy or before they develop some complication of diabetes. So these women should be closely followed up. And as Swati as well as Lotika has said, that the preconception, the women should be screened even from the puberty itself, should be counseled for that. So all known type 1 diabetes, known pre-diabetes, known type 2 diabetes, if planning your pregnancy, please go for the preconception counseling and care. And 90% of the pregnancies, unfortunately, are accidental pregnancies. Saab galti se ho gaya. That galti se ho gaya becomes a problem for we as a doctor. And that is why you should always go to the preconception counseling care, achieve your targets on safer medications, and then become pregnant. So you take the fitness from Ajoy Tiwari or Swati Srivastav or Latika Purohit and Ashok Kumar Das or Usha Sriram. Take the fitness for pregnancy. You go for fitness for cataract surgery. You go for fitness for hernia surgery. Now you take fitness for pregnancy. before you become pregnant if you already are known type 1 or type 2 diabetes. So these are the final messages for all of you. With this, I stop here. And thank you very much, everyone, for joining with us. And hopefully we'll be meeting again in the next PregaTalk, which is expected to be in some other language. Thank you very much once again. Once again, every one of you, Happy New Year 2025. Remain healthy always and keep yourself healthy and happy always. Thank you very much.
Sunil, thank you very much for this great job that we're doing. I also would like to thank as a senior person, Swati, Ajay, and Niti, and of course, Latika. Great endeavor, and it will definitely be fruitful. Thank you.
Thanks.
Thank you very much.
Thank you, everyone.
Thank you.
I'll leave now, Swati. Leave now. Sunil.
Thank you, sir.
Thank you.
नंदकिशोर जी, रिकॉर्डिंग स्टॉप्ड, बोला नहीं आपने अभी तक?
Recording stopped.
तो भैया पहले कर देना था ना. चलो ठीक है, हो गया. चलो बाय, गुड नाइट.